This is the operator from Global Crossing. The training has now begun, and all participants have been placed on mute. You will remain muted until the question and answer period during the last 15 minutes of the seminar. Kelly Musco at the Francis J. Curry National Tuberculosis Center will coordinate today's seminar. Kelly?
Thank you. Hello, everyone, and welcome. This is Kelly Musoke, and I'm a program manager here at the Curry Center. I'm here with Bob Seidel-Kahn, our distance learning coordinator, who will be helping to coordinate today's course. Today, there are over 800 participants joining us from across the United States. You should be able to see a seating chart on the lower left-hand corner of your screen, where each square represents an individual or group that has logged in. The Francis J. Curry National TB Center is one of 4 regional tuberculosis training and medical consultation centers in the country. These centers are often referred to as RTMCCs. The Curry Center covers jurisdictions in the western region that include the following locations. This project was funded by the Centers for Disease Control and Prevention's Cooperative Agreement and is a collaborative project of the San Francisco Department of Public Health and the University of California, San Francisco. I'd like to take a moment to acknowledge all of the members of the Course Advisory Committee who are involved in the development of today's training. Several of them are going to be presenting to you today. Thank you all for your contributions. The center is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. And the center is also approved as a provider of continuing education by the California State Board of Registered Nurses. This web-based seminar is approved for a total of 1.5 continuing education contact hours. To receive your continuing education contact hours, you must complete the online evaluation. The website for the evaluation will be emailed to all registered course participants immediately following the seminar. All of today's faculty members have signed a declaration of disclosure. And today we are using Global Crossing's live meeting software for our web-based seminar. If you need technical assistance during the workshop, please call this 888 phone number for support. And now it's my pleasure to introduce today's facilitator, Dr. Lisa Chen. Dr. Chen is the medical director at the Francis J. Curry National TB Center and also works in the Pulmonary and Critical Care Division at UCSF. Lisa?
Well, thank you, Kelly. Good morning, good afternoon to all of you joining us across the country, many of you in snowy places as we speak. I'd like to flash this slide with the course objectives, which of course you could read, but I just want to shout out a thank you for this topic idea to some of the folks from our region. Denise Ingman from Montana first raised the issue of doing a webinar based on some of the problems we face in serving our clients with alcohol use, and Gisela Schechter from the California State Program also raised the flag for giving some voice to the tobacco issues surrounding TB. Today's agenda will begin with a talk on the epidemiology of alcohol and cigarette use among people with TB in the U.S. From Eric Posner. We'll then move on to some of the clinical complications in management of treatment in patients with both TB and alcohol use with John Bernardo and Claire Murphy. And then we'll move from there to issues surrounding tobacco use with the clinical complications and behavioral interventions for tobacco and tuberculosis with Tom Novotny. At the end, we'll have some time for discussion amongst the faculty, and also, if we have enough time, we'll open up question and answer session through the operator. So moving on to our first speaker. Whoops. There, thank you. They shouldn't let me do the technical stuff here. Our first speaker today, I'm very pleased to introduce to you Eric Posner, who is an epidemiologist with the International Research and Programs Branch at the Division of TB Elimination with the CDC. Eric, as I said, will be covering the epidemiology, and I'm just going to pass this virtual microphone right over. Thank you, Eric.
Thank you, Lisa. There will be 2 parts of my talk. In the first part, I'll be describing the prevalence of alcohol abuse and tobacco use amongst people with TB in the U.S. And I'm going to spend some time focusing on the interrelatedness between alcohol abuse, tobacco use and the implications for TB control programs. So in this figure, we have data from our national tuberculosis surveillance system. These are all verified cases and culture-confirmed cases of TB in the U.S. reported to CDC. And this is excess alcohol use among people with TB greater than 15 years by sex and nativity from 1997 to 2006. And immediately when you look at this figure, I think there's two things that jump out at you. You can see on the vertical axis we have the prevalence of reported excess alcohol use. On the horizontal axis, we have the two groups, U.S.-born and foreign-born. Well, obviously, you can see the bars for the U.S.-born group are much greater than the foreign-born group. And the other thing that you can see is that within each of these groups, the silver bar is the greatest. So let's focus on the U.S.-born group first. Overall, 23.2% of people with TB in the U.S. reported excess alcohol use. And it's much greater amongst men at 29.2% relative to women, 11.7%. If we switch to the foreign-born group, overall 7% reported excess alcohol use, with 11% of men and 1.1% of women. So you can see excess alcohol use as reported by people with TB is far greater amongst U.S.-born and also men. When we look at the prevalence of cigarette smoking amongst people with TB in the U.S., unfortunately, we do not have any national estimates of smoking prevalence amongst people with TB in the U.S. It's not captured by our surveillance system, which is somewhat surprising considering that TB is primarily a disease of the lung, and smoking is a behavior that causes a lot of morbidity and mortality, and primarily in the lung. So since we don't have data for people with TB, let's see if we can get some understanding of what we might expect if we did have data. So let's look at first at prevalence of current cigarette smoking among adults in the United States. Overall, we know that 20.6% of adults report current cigarette smoking. It's greater amongst men at 23.5% compared to 17.9% amongst women, and it's even greater at 31.1% among people below the federal poverty level. 28.5% amongst people with less than a high school diploma relative to 5.6% amongst people with a graduate degree. So similar to what we see with TB in the United States, smoking is greater amongst people that are poor and have less education. Now, what about the prevalence of current cigarette use amongst groups at high risk of TB in the U.S.? Well, national data show that 51% of people receiving HIV care reported current cigarette smoking. 73% of people experiencing homelessness reported current cigarette smoking. And then if we look at the 5 countries that contribute over half, or 56%, of foreign-born cases of TB in the U.S., in the table you can see those top 5 countries: Mexico, Philippines, Vietnam, India, and China. And relative to the U.S., amongst men, all of them have a much greater, or have a greater prevalence of smoking, some much greater. For example, Philippines at 47.7, Vietnam at 47.4, and China at 52.9, much greater than what we observe amongst men in the U.S. at 23.5. We look at women, the prevalence in each of the countries is less than what's reported in the United States. And overall, several of these countries have a total prevalence, men and women combined, that is greater than what we observe in the United States. So in looking at these groups that contribute to a great burden of TB in the U.S. and our higher risk groups, HIV, homelessness, and foreign-born, we can see that current cigarette smoking is greater than what is observed in the general population, and we could likely expect to see that in our people with TB. Now, what about the association between alcohol and tobacco use? Well, if you look at people that drink and want to know what is their prevalence of smoking, amongst heavy drinkers, 56.3% reported current smoking. Among people that reported current use of alcohol, 18.5% reported current smoking, and that's compared to 15.9% that reported not drinking. Next, let's look at people that smoke, and what is the prevalence of drinking there. Well, amongst current smokers, the prevalence of heavy drinking is 16.4% relative to non-smokers at 3.9%. The prevalence of binge drinking amongst current smokers is 44.8% relative to 17.2% of non-smokers. And you can see for current use, it's 67.1% relative to 47.2%. So overall, amongst people that drink, you've got much more smoking than what we see in the general population. And among smokers, people that report smoking, you've got a much greater prevalence of heavy and binge drinking. We have several common risk factors associated with TB disease that tend to be a great deal of our focus with national guidelines and intervention. Those groups are people experiencing homelessness, people with HIV infection, people in high-risk occupations, people that have lived in congregate settings, recent immigrants to the U.S., and then substance abuse. So we know that substance abuse is a problem for TB control programs, but where does it rank to other common risk factors? Please rank how prevalent you think substance abuse is relative to these other risk factors, with 1 being most prevalent and 6 being the least prevalent. In the audience, please go ahead and use your computers to vote, again, where you think substance abuse falls, number 1 or number 6 is prevalent relative to the other risk factors that I reviewed. All right, I'm trying to unhide the results of the voting. I don't know if it's visible to people. All right, let me go back. Well, I'm not sure if you could see the results of the voting, but substance abuse is the most prevalent risk factor relative to the other that reviewed. This is amongst all verified and reported cases of TB in the United States from 1997 to 2006. 17.2% of all people with TB reported substance abuse, and 79% of that substance abuse is excess alcohol abuse. Excuse me, we've seen. And that's relative to recent immigration, which is next at 14.9%, HIV, which is 7.3%, and this is the most recent, the 2006 data point. 6.3% for having lived in a congregate setting, 6% for having experienced homelessness, and 4.3% for high-risk occupation. Now, if we look at these same data and restrict it to people that were born in the United States, we can see the gap is even greater, with almost 1 in 3 U.S.-born people with TB in the United States reporting substance abuse, and this far exceeds the other common risk factors that we tend to focus on. So what about the interrelatedness between alcohol abuse, tobacco use, and the implications for TB control programs? We know that people that smoke are at greater risk of TB infection and progression from infection to TB disease. We know they're at increased risk of dying from TB, and there's a dose-response relationship. So the more smoking, the greater the risk of progression to TB disease and the greater risk of dying from TB. We also know that people exposed to secondhand smoke have greater risk of infection and progression to disease. So cigarette smoking has an impact on not just smokers, but also non-smokers' TB risk. We know that people consuming greater than 40 grams of alcohol, which is approximately more than 4 or more beers per day, or having an alcohol use disorder, have 3 times the risk of TB disease. Amongst people with TB in the U.S., we know that substance abuse is associated with sputum smear positivity, with an odds of 1.6 for people that abuse substances versus those that do not. And we know that the relationship between being smear positive and abusing substances is modified by HIV infection or not. So those not HIV infected have an odds of 1.8 relative to 1.2 amongst those not infected for being smear positive. And this relationship is not surprising. Consider people that are HIV infected are more likely to have compromised immunity and therefore more likely to be smear negative. We also know that substance abuse is associated with TB treatment failure, an odds of 1.9. And this relationship between treatment failure and substance abuse is also modified by sex. So women have an odds of treatment failure that abuse substances, have an odds of TB treatment failure of 2.4 relative to males at 1.5. We also know that people that abuse substances were more likely to be involved in a county-level genotype cluster with an odds of 2.3. This is indicative of recent transmission. So just to review, we know substance abuse is associated with smear positivity, failing treatment, and being involved in a recent genotype cluster, which is indicative of recent transmission. In this figure, we have several core TB control measures on the left. And on the right, we have smoking and substance abuse-related barriers. So our first TB control measures, our goal is normally to diagnose disease. So normally we have someone that comes in and there's a diagnosis of TB disease. And we know that substance abuse is a barrier because it's associated with smear positivity, so people being more likely to be infectious, and delayed care seeking, so there's prolonged infectiousness. We also know that because of smoking, that people that present for cough may often be misattributed as a result of smoking and not TB, therefore leading to delayed diagnosis. The next core TB control measure is that we want to investigate and identify to determine if there's additional cases and all the contacts. And what we know is that people diagnosed with TB that abuse substances are often unwilling and sometimes unable to recall or report all of their contacts, that leading to incomplete contact investigations and more people progressing to disease and sometimes ongoing transmission. The next core TB control measure is screening contacts for TB disease and latent TB infection. We know that people that abuse substances are more likely or more difficult to locate, less likely to get screened, and again, there's the possible misattribution and common misattribution of smoker's cough rather than coughing being a result of TB. The next core measure is to provide treatment and preventive therapy. And we know that people abusing substances are less likely to initiate, adhere to, and complete treatment or therapy. All this inhibiting our ability to reach our ultimate goal, which is treatment, cure for disease, and completion of preventive therapy for those in infection. So in summary in this talk, I think we've shown that the prevalence of alcohol abuse and likely also cigarette smoking among people with TB is much greater than what we see in the general population. We know that there's a lack of national data indicating our inattention to the impact of smoking on TB control. There's a strong association between alcohol abuse and smoking, and we know that substance abuse, 79% of which is alcohol abuse, is far more prevalent than other risk factors that we tend to focus on in the U.S. Alcohol and smoking are both associated with an increased risk of TB disease. Smoking and alcohol abuse are associated with smear positivity, treatment failure, and transmission. So alcohol abuse and smoking interfere with TB control programs on multiple levels and are therefore deserving of greater attention and resources. So in closing, when we look at the epidemiology of TB in the U.S., my colleague, Dr. John Altman, who's sitting beside me, is fond of a quote by Dr. Michael Eidman that says that the epidemic tide of TB recedes from the shores of America. Small tide pools of disease remain behind, pools populated by immigrants, the elderly, and immune-compromised. Well, based on the data, we believe there's an often overlooked tide pool deserving of more attention. And that tide pool is a complicated mixture of alcohol abuse and tobacco and illicit drug use, as we've shown today, but also of unmet mental health needs and homelessness, all of these inhibiting our TB control efforts. Thank you. I want to just acknowledge and thank the contributions of my colleagues, Dr. Altman and Dr. Moonen, for their input on this talk. Thank you.
Great. Thank you, Eric, as well. Well, I think that an interesting point is really Eric's data brings to light what many of us who work on the front lines of TB understand and know and deal with every day is the impact of alcohol on our practice with our patients with TB. And here to speak to the issue of alcohol and TB, we bring you I'll describe as the dynamic duo from Boston, both working for several years with the underserved populations in that urban setting. John Bernardo, who's a professor of medicine at Boston University and the TB controller for the Commonwealth of Massachusetts, and Claire Murphy, as I describe her, as one of our treasured public health nurses, also at Boston University and with the Veterans Affairs Hospital there. John and Claire, I know you're buried under snow, but I'm glad you joined us. Please go ahead.
Thanks, Lisa.
Thank you, Lisa. I think I'm going to start. I'm sitting here at Boston University, which is closed today, and watching the snow blow across from left to right across my window. It's very unusual around here to see the streets not plowed. Claire is way off at the VA working over there, so we can't punch each other in the arm as we're doing this like we usually do. But nevertheless, you're going to get this from the both of us. So we like to live and die by guidelines. And guidelines, although we like to believe in them, have always been a source of controversy. Back in 1904, there were no CDC guidelines for the treatment of TB, and I think Claire even remembers that there was no treatment for TB back then.
Thanks, John.
But here in a letter to the editor of the New York Times is a quote from the then Commissioner of the Food and Drug Administration, Dr. Wiley, touting alcohol as being useful as a nutrient for people with tuberculosis. And the response here is from a physician who was practicing in New York City who read the article, claiming that my experience has convinced me that although alcohol can never be considered a food for the consumptive. So we have been mired in controversy since then.
But we also know that this comes in contrast to the way most of our patients feel, that alcohol is good enough for their tuberculosis to cure it.
That's right. Of course, the line between use and abuse is difficult to define. The CDC Behavioral Risk Factor Surveillance System in 2009 reported that 5.1% of respondents in the United States reported drinking more than 2 drinks per day. I think that's a generous number. And since there is an association between TB and alcohol abuse, the CDC includes excess alcohol use, and in quotes, in its RVCT reporting system. In this slide, we see the reported cases of tuberculosis in 2009 and 2005 to show that the cases reporting excess alcohol use at about 13 to 14% in those 2 years, with a decline in the percentage over time. And as Eric pointed out, the abuse of alcohol reported is more common among U.S.-born people with tuberculosis. Unfortunately, there's no standard definition of alcohol abuse, and the guidance that we receive in reporting this is based largely on self-report of use of excess alcohol without any measurement of grams or number of drinks over a period of time, or other information largely from the medical record that might indicate that one abuses alcohol. So these numbers are not very rigorously reported or determined, as we can see. And they may vary from location to location. Fisk, in an article published in the Journal of Infection in 2009, reported that in North Carolina between 1994 and 2006, 23.7% of their cases reported excess alcohol use, and this was also greater among non-U.S. born people. So how does alcohol affect tuberculosis? Well, we're not really sure about mechanisms, but we do know that alcohol can affect one's susceptibility to disease, the extent of disease, and it can be associated with delays in diagnosis and consequent extended transmission, and it brings up all kinds of treatment and monitoring issues among people who abuse alcohol. Well, we're not really sure exactly what the determinants of host susceptibility or resistance might be in humans with respect to tuberculosis. And we're not really sure how alcohol affects those determinants of susceptibility and resistance. In 2004, using a mouse model, Mason and colleagues fed mice either a diet of alcohol or standard liquids, and then injected them after a time with a virulent strain of tuberculosis via the tracheal route, and then measured several parameters of the innate immune system. They found that alcohol-fed mice had higher overall organism burdens and impaired specific cell immune responses to TB in vitro. So 100 years after the letter to the editor of the New York Times, this is the level of understanding that we have about how alcohol might affect our ability to become infected and sick with tuberculosis. Alcohol also affects tuberculosis in other ways, including social situations, as pointed out by my friend Ed Nardell in his paper in the New England Journal in 1986, describing exogenous reinfection among guests at the Pine Street Inn Shelter in Boston, where we do a lot of our work. These guys, and they were all guys, were alcoholics, and they associated with each other in various places around the city, and he showed that there was transmission of TB from one person to another because of the social situations that they were in. We do know that the overall risk, though, is increased. As Eric pointed out in a review of 21 studies, Lonroth showed that consumption of about 3 beers a day or more, or a diagnosis of alcoholism, increases one's risk for tuberculosis by a factor of 3. There are relatively few studies that correlate specific alcohol abuse and the extent of disease of people with tuberculosis. Most studies combine alcohol abuse with general substance abuse. In their study that I alluded to earlier in North Carolina, Fisk found a large overlap between alcohol abuse, homelessness, and general drug use in the population with tuberculosis reported over the 12-year period of time studied. Among those persons, pulmonary disease was more common in alcoholics. In addition, there was more cavitary disease and more sputum-positive disease among the alcoholics when compared to the non-alcoholics. It was unclear in the study if alcohol led to increased transmission, and there was no difference in completion of therapy between alcoholics and non-alcoholics. In another study in Texas, Moran and colleagues found that there was no association between alcohol abuse and cavitary tuberculosis. So there are very many well-recognized issues that result in delays in diagnosis and extended transmission among people with alcohol abuse who develop tuberculosis. Well known is the main issue of access to health care, which relates to either issues with the system, such as having or not having health insurance or access to clinical care, or recognition of illness among people who see the patient and refer them to appropriate care. In addition, there are personal priorities where, among our patients, we find that alcohol is more important than almost everything, including sleeping in the cold and in the snow. So among our folks, we find there's a lot of denial of illness and a lot of self-motivation towards getting alcohol more than anything else, including nutrition and seeking health care. And as Eric pointed out, there are often problems with contact investigation, and many of you know that people who abuse substances and alcoholics are not very rigorous in identifying contacts. Therefore, we have missed opportunities to prevent new cases and new cases arising in the community among those people who are recently infected and not identified and placed into treatment to prevent disease. I mentioned FIST study in North Carolina that showed no differences in completion of treatment. There's a study from Germany that was published in 2003 that reviewed cases in Hamburg between 1997 and 2001 and found that the risk of non-adherence was almost 6 times worse in patients with alcohol abuse or injecting drug use than it was in people who did not have these issues. And lastly, there are treatment issues. As I mentioned earlier, there are systemic issues and personal priorities that get in the way of identification of disease, diagnosis, and treatment. Case management is one way to facilitate treatment, to provide access to medications by making sure that regardless of who pays for the medicine, the patient gets medication appropriately. Make sure that the patient takes the medication appropriately and safely. So directly observed therapy is one strategy for doing that within the case management system. And where necessary, the need to institutionalize somebody, either voluntarily or enforced. And here I have a picture of the Shattuck Hospital TB treatment unit that's run by Marie Turner over here in Boston that is well known for its management of patients with drug use and alcohol abuse. And lastly, case management can facilitate identification of contacts so that contact investigations are more rigorously done and patients who are identified are treated appropriately. Now, people who drink continue to drink, and even when you develop good relationships with people, we find that it's very difficult to get them to stop drinking. And this brings in issues of toxicities from the medications, especially those that involve the liver, and behavioral issues, because people who are drunk don't always show up for their clinic appointments, and we have to go out looking for them. Treatment defaults and delayed completion of therapy may be minimized by case management. And in FIST study, they pointed that out as one of the reasons why they might have had better completion rates in their alcoholics, because they may have gotten more attention because of case management. So how do we do it here in Boston? This is a picture of the entranceway to Pine Street Inn, and it looks pretty good because there's no snow there right now, and there are leaves on the trees. But in 1986, we reported an outbreak of tuberculosis among the guests at this shelter, and as shown here in the publication MMWR, where we had 3 cases in the year 1983, we had 19 cases in 1984, and 50% of those cases were resistant to isoniazid and streptomycin. And these cases formed the basis for Ed Nardell's study on the exogenous reinfection of tuberculosis among the alcoholic patients. I'm going to pass this on to Claire right now, who will go on and talk about what we do at Pine Street and how we run it.
Thanks, Johnny. Now the evidence is out, because clearly our audience is going to see in the slide who is the hard worker and who is the photogenic person here. So thank you guys for hanging on with us. And as John mentioned, I'm going to talk a little bit about some interventions. And, you know, sometimes you're lucky enough to get the opportunity to develop an infrastructure that allows you to support a high-risk population, such as the homeless, where you can engage the comorbidities of a multitude of issues but especially alcoholism, where you can engage it head-on and try to address some strategies that will help us with what we call one of our most endearing opponents. And if you look at the slide, you can see pretty much very informative. We are afforded the luxury of being able to offer a TB-specific clinic at one of, again, the biggest shelters in the city of Boston, which today will be jammed to the rafters, so John is going to have a delightful time tomorrow night, that I will not be joining him down there seeing all these patients with that lovely snowstorm. But fortunate enough to have people who are TB people and who work very, very closely with the primary care. You know, we try to have relationships with our patients, but also accepting that our primary care relationships are very strong with our patients. A lot of the patients that we see in the clinic are referred mainly by our nurses, by shelter staff, and our in-residence counselors are very much in the queue to mark those patients that may be coughing, may be exhibiting symptoms that look like they need to come and visit us in the clinic, and utilize what we've trained them to do is what's a cough log. We're also, again, fortunate enough to have the availability of a wonderful X-ray machine on the campus there that allows us to do films right there and not send the patients up the street where they might get lost in the abyss of the major medical center. Lab work is available there, and we're also able to do the electronic medical record. So we're not relying, God bless Barbara McGinnis, one of our old public health nurses. Often we had to rely on her, what was in her head and what was on a piece of paper. But the electronic medical record has helped us immensely in doing this. But this is bringing care to the patient, and as John mentioned, sometimes with the drinking, it's hard for the patients to remember to keep appointments. But here, where the clinic is housed right in the shelter, we're just downstairs. And many a night, we have to go upstairs and drag them out of bed to come down and see us. We're fortunate to have these evaluations on site by us where we can look at some of those comorbidities and look at questions like, have you ever had any problems with HIV? We can offer testing for HIV. How about hepatitis? And what do you do with those patients that are identified as having hepatitis C? Do you start them on INH and say a couple of prayers? Well, you know, for us it really depends as clinicians on how severe the hepatitis C is. Often we will see the patient first, obtain the necessary blood work really diligently with their primary care provider to find out what the status of the hep C is. Have they been treated before? Are they in the midst of treatment? You know, ideally we'd like to get them treated for latent TB infection and then work on their hep C. But sometimes it requires a little bit more coordination, and as a team approach, we're able to elicit the help of a liver specialist. That way we're all on board. Patient safety is always, always, for all of us, key to their treatment. We work a lot with them, as all of you do with all your patients, on really emphasizing to have adherence issues, to be taking that medication. We offer 2 different regimens, INH for 9 months or rifampin for 4 months, as John just mentioned.
Yeah, the rifampin treatment protocol that we use follows the CDC guidelines, which actually is not based on a lot of evidence. One of the studies that was done to support the use of rifampin for 4 months is a study that we actually did at Pine Street as a result of that outbreak that Andrea Pileski published in the Blue Journal in 1996, where we followed recent converters as a result of the outbreak who were treated with either isoniazid, rifampin, INH plus rifampin, or nothing because they defaulted or did not want to receive treatment. But as I mentioned, the evidence for rifampin's effectiveness is not very clear.
Thanks, John. And you may not usually start the INH. You know, for all of you that work with sometimes most difficult patients, sometimes it's just establishing that relationship. We may decide that first night that we need to have a couple of other visits with them before we start the medications. You know, we also are into engaging the patient, but mainly to do a lot of patient education. You know, stop the medicine. If you're having those side effects and you can't reach us, you have to stop the medicine. We may decide we want to see you weekly. We're worried about your liver. And sadly, often providers, even clinicians, and even the general public assume that homeless clients or patients, guests, whatever you want to refer to them, are not able to actively engage in initiating health care measures. They feel that, well, you know, perhaps they're drunk all the time, they don't know. But boy, unless you've worked with this population, you have to tell people you're wrong. I know when we started clinical trials years ago back with TBTC, there were some of our colleagues that were very much surprised that one of our recruiting sites would be a shelter because they worried about compliance and adherence rates. And how are you going to get somebody through 9 months of INH? They get randomized to that arm. But I will tell you, and as our colleagues know, the shelter had the highest adherence rates, both inside and outside the clinical trials. Many of our patients are very much educated about their health issues. They want to be asked to participate in it. They don't want someone just telling them, no, you need to do this, come back and see me in a month. They're very much actively engaged in what's going on in their body. And there are those, too, that need a little bit more help in facilitating optimum health initiatives as well. And, you know, back in, just to throw out, back in December of 2008, I teach nursing students through Simmons College and Boston College, and had the students do a feasibility study. First of all, the patients were absolutely beside themselves that anybody cared what their insight was about programs such as smoking cessations programs. It was an eye-opener for the students as well as for the providers there. Because those of us who work with TB know that our patients want to be part of their care. Most of them want to be absolutely involved in this from the get-go. What our students were able to elicit from their feasibility study was not only were the patients there interested in smoking cessation, but they wanted it to be mixed with substance abuse. They felt that programs of this nature that were provided to them where they lived would be of the utmost importance to them, and they were very excited about it. So that's something that we also need to think about. And then moving on here. You know, homeless people get a bad rap. Everybody thinks only homeless people drink. And those of us who know that there are others out there that are drinking and they're not homeless. And why is it? Why do we just assume when we see that homeless patient coming through that they're the ones we have to worry the most about in their alcohol? And, you know, we know that alcoholism knows no boundaries. It can be any age, any sex, anyone. And this particular reference here shows many of us, especially those of us that have children, are concerned of the number of children that are drinking. And this is self-reporting, that they have consumed alcohol in the past month. And the rate continues to increase with drinking. So it's out there. And what do you do with a teenager that you are seeing back in follow-up who's demonstrating abnormal LFTs? Are we to assume it's something else going on? You know, we have to think about that it could be drinking. And then the college student who admits to drinking just a few. Well, what is just a few? Is it 2 a day? Is it 6 a day? Or is I only binge drink on the weekends? So what are we thinking? You know, when that young child or that teenager that's coming in, pulling that teenager aside and having a little one-on-one with them, very difficult sometimes when you have a mother peering at you or a father peering at you, but sometimes removing the guardian for a few minutes while you do the exam, and it's okay. Parents are used to sometimes being asked to leave the room while their children are interviewed, and really sitting down with the child and saying, so what's going on here? You know, let's talk. I'm not going to speak to your parent, but this is important. And education has always been the key. So what you see up for the next slide now is just an example of screening. Think about screening for daily alcohol use with all our patients, not just our patients that are showing up, but with all our patients that come. This is one example of a screening tool that we have that we can use called the audit screen, but many more of you might be more familiar with what is called the CAGE questionnaire. And if you take a pen and paper, for those of you that are new to the CAGE questionnaire, have never heard about it, For the rest of you old-timers out there, you can take this couple of minutes, refresh, quick nap, whatever your pleasure is. But with the CAGE questionnaire, and there's no slide for this, so don't look for it. This is just an added bonus. CAGE questionnaire is just 4 simple questions that we ask the patient. And it's not a diagnostic tool, but it's a screening tool to find out some information about the quantity, the frequency, or even their pattern of drinking. So the first question you would ask the patient is, do you ever feel the need to see or cut down on your drinking? Second question would be, have you ever felt annoyed? And that would be A, by criticism of your drinking. The third question would be, have you ever had G, guilty feelings about drinking? And finally, E, have you ever taken a morning eye opener? What's really interesting is this simple mnemonic is only 4 questions. There's a multitude of tests out there. There's a Michigan alcohol screening test. There's the alcohol use disorders. If you were just to go on Google and should just Google in there, alcohol screening, you'd come up with a couple. But again, it's just there to sort of give us an idea. And what's really interesting is that alcoholism, as we heard, tends to be overlooked. And we have to be out there, we have to be screening these patients. You know, the tragedy of alcoholism and other addictions is that they really respond to treatment. And while cure shouldn't be expected, helping a patient to get into recovery programs such as therapy or medication or the self-help programs like AA can do a lot of good. You know, when you ask patients how much they drink, I don't know if you guys, but this is kind of comical for us, it usually leads to an estimate that's lower than the actual number of alcoholic drinks a day that they do. So I'm asking a patient, how many drinks have you had? 2 or 3 drinks may be very deceiving to themselves as well as the clinicians who are seeing them. And as John mentioned, you know, denial is a very great state to visit, we always tell people. It's a very common mental mechanism among individuals. And it cuts across all paths. And the thing to remember is that most people with alcoholism, they don't look like your, quote, typical alcoholics, as you see in pictures, unless they're sort of in an advanced stage or they're really difficult to treat. So we must always keep it up there at the top of our list about symptoms and go press that patient who seems to be kind of evading your questions about any kind of substance abuse. So as John mentioned before, nursing case management, there is help, you know, in nursing case management for either LTBI, but most often for active disease. And God bless the public health nurses, because they truly, and I'm not just that I'm biased for being a former public health nurse, but you truly are the eyes and ears of our patients out there. You are the relationship builders. You are the ones that make it happen when everybody else says it's not going to happen. The patient's not going to complete their medication. They're drinking, they're using heroin, they're not going to get it through. You are the ones who persevere. So in Massachusetts, one example that we have is a Menafort, which allows us to take a patient and actually, unfortunately, lock them up against their will if they're found to be in danger to themselves or to anybody else. It allows for due process, and it gives us 15 days observation in Marie Turner's unit there at the Shattuck. Fortunately for us, really do we have to use it, because it is, again, the relationship building and the determinants of the public health nurses that makes this law, though still on the books in Massachusetts, very, very rarely used. So, again, for you great guys out there, public health nurses, I don't need to remind you. Nice home visits frequently do not occur in nice homes. Often, as the public health nurses know, we visit our patients wherever they will see us. And one experience of a nice home visit for me was a nice watering hole called The Clock. Located in South Boston, it has been the prime locale of multiple TB outbreaks over the last 20 to 25 years. And often in tracking down a patient, I would first start here. And there would be no surprise because there would be some of my former patients sitting at the bar and would be the most instrumental in helping me track down my current suspect. So a little INH goes a long way. This is Mr. Walsh. Mr. Walsh and I are having a lovely conversation, 9:30 in the morning at the clock. He is finishing up his 7th month of INH for LTBI after being exposed to one of his best friends there, who unfortunately was smear positive. And Mr. Walsh liked having the companionship of a fellow Irish partner in there, I think, to work with him. And I will tell you that, fortunately for us, Mr. Walsh did complete. You know, he was one happy ending. He was somebody who, in the very beginning, agreed to a contract of not having any alcohol. And we worked with him, and the buyback with him was, as long as his LFTs were going okay, that I would trust him and I would believe him. And we were fortunate enough to get him through 9 months. We know that it doesn't always happen that way. Our best efforts. Several of our patients at Pine Street, we know for a fact, are washing down that INH with Heineken. And again, it goes back to just continuously monitoring those patients as we do with their visits, continuing to hit them with the education. At several times, patients would show up for visits, and clearly when you make that assessment that they are drinking, all medicines are put on hold. And you know that it's almost like a lifelong deal to get them through 9 months of medication. But we're absolutely able to get a majority of people to do it. And again, I think it's all about the relationship building. With Mr. Walsh here, again, he did fantastic. He was able to finish up. And wrapping up these slides, just to remember, just in summary, screen all the patients, not the ones who look like drinkers, but everybody. How many drinks a day are you taking? And remember, again, it's self-reported. Add another 4 or 5 to whatever they tell you that they're doing. And in the famous words of my Irish grandmother, Shlanta, which is an Irish toast to good health, and I tell that to the patients, but can we think about making the toast with 7-Up instead of alcohol? And I thank you, and I'll leave you there.
Well, thanks, Claire and John. That was excellent. Really, the real-life voice of experience telling us to go ahead, forge ahead. There are ways to actually make it work. We're going to switch directions for a minute now, and I'd like to introduce our next speaker, who is Tom Nirvani, a professor of epidemiology and biostatistics and the director of a global health PhD program at the Graduate School of Public Health at San Diego State University. He's worked on all phases of tobacco control and has a recent interest in developing research around the implementation of smoking cessation in TB clinic programs. An interesting fact is he also plays the clarinet at the local Coastal Communities Concert Board. And of our speakers, everyone's stuck with snow, even Eric in Atlanta, but Tom actually was seeking snow, so he's calling in from the mountains. Tom, thank you for joining us. I'll let you go ahead now.
All right, thanks very much. It's a pleasure. What a opportunity to emphasize the importance of to weed together tobacco use and TB. I think it seems like a no-brainer. And the kind of research.
Excuse me, Tom, we're having a little bit of problem hearing you through your cell phone now. I don't know if you could make an adjustment and try again. It's breaking up.
Is this any better?
Yes, that's better. Thank you.
Okay. I will try to speak clearly into the cell phone, but again, I'm up here in the mountains and maybe not the best reception. At any rate, weaving together TB and smoking seems like a no-brainer because of the effects on the lung that both of these conditions have. But what I've found is that it's really hard to join the sort of infectious disease folks and the non-infectious disease folks in approaching this together. And so what I'll be talking about today are some of the pieces of evidence that I think will be useful in understanding this relationship between smoking and TB, and some of the work that is being done to try to join both smoking cessation and TB control together. And I think you all know about the relationship between tobacco use and many of the non-communicable diseases that really dominate the causes of death globally as well as in our country. Ischemic heart disease, vascular disease, or stroke, chronic lung disease, respiratory infections of all sorts, including TB. And you've heard some of the evidence that Eric Posner brought forward on the impact of smoking on mortality, morbidity, and even spread in households or contacts of TB-infected people, that smoking increases these risks. And so one might ask, is actually smoking and tobacco use causally related? And that means that there's a dose response, that there's a biologic plausibility, that there's a strength of the association, that there's a repeated association found in different kinds of studies, and that when you remove the risk factor, smoking, do things get actually better? And that's the question that we really haven't been able to answer yet, and I'll talk more about that in a bit. Well, TB is, as you know, a major global burden of disease. We've talked a lot about poverty and homelessness and the other kind of social incidents. The global incidence actually peaked in 2004. It's down a bit, but that there are still increasing numbers of cases. Even though the incidence per 100,000 is lower, the number of cases is up now to 9.4 million in 2009. And as we also I think can all understand that there's a lot more people that are infected with MTB, latent TB, and that there's about a third of the global population that may be. Now, one of the major approaches globally to TB control is DOTS. This slide's a little bit goofed up here. Sorry about that. But 94% of the population of the world lives in areas that are covered by directly observed therapy short course, which is WHO's clear and simple approach to treating TB for much of the susceptible populations. The only problem, though, is that even with DOTS and the intense attention that it gets with daily observed therapy for 6 months or so, it's not enough to meet the global goals that we've set for TB, which is to cut the prevalence and the deaths due to TB in half by 2015. So it's not enough, really. The point here is not enough, really, to just do clinical treatment of TB. And you've heard a lot about alcohol and a bit about smoking. So let's talk more about that. Now, you also heard a little bit about the relative risks of some of the other factors on TB infection. And the WHO, the World Health Organization, recently did a systematic review to show what the effects of smoking and tobacco use were on TB outcomes, even when controlling for the effects of alcohol, socioeconomic status, age, gender, and other potential confounders. And so even with consideration of those, there's strong evidence to show that tobacco exposure, both active and passive, can increase TB infection, TB disease, where there's fairly strong evidence, passive smoking, where there's fairly strong evidence, active smoking and recurrent TB, that there's fairly moderate evidence, but that's still, significant risk factors of at least 2 to 3 times as much the risk of recurrent TB for active smokers. And so the whole idea of constant attention to this, not just during the time of TB treatment, comes to mind. And so this is, what we as epidemiologists think about in terms of, well, what can we do to reduce this risk, and what is the impact if we do reduce the risk? What will happen to the mortality and the morbidity of TB if you get rid of smoking as a risk factor? So what we look at is something called the population attributable risk. And that means the proportion of disease that could be eliminated in the absence of this risk factor, i.e. if everybody with TB who smoked stopped or never started. Well, if we assume that the prevalence of smoking among TB patients is about 30%, which I think in the U.S. is pretty expected, and that the risk of TB among smokers, as we've shown, is about 2 to 3 times that of non-smokers, then we can do a mathematical calculation, and epidemiologists do this kind of stuff all the time, where we can show that about 22 to 36% of incident TB cases are attributable to smoking, so that a third of incidents of TB might be eliminated if we were to eliminate smoking from those who are susceptible to TB. Well, secondhand smoke may also add to this. That's passive smoking exposure as well. So if we were to then compare this concept, rather than just the risk of smoking, but the actual elimination of TB, the population attributable risk, due to the various risk factors, we can see that smoking moves up the list to about number 2 compared to malnutrition, above alcohol, and above HIV, and above diabetes, which is also another unsung risk factor for TB. Well, anyway, that's sort of theoretical. If we can eliminate all the smoking, this is what we would come up with. Let me just put a question out here to see how many people now can think a little bit more about the proportion of new TB cases that might be eliminated if none of the TB patients smoked. Looks like we did pretty well. I'm going to open up the results here. I hope. The results are shown. Okay, so it looks like most people get it. About a third or so of the cases could be eliminated with smoking. And then how does tobacco rank in terms of a complicating risk factor for TB? 5th, 2nd, or 1st? So we can show the results, and most people are getting this now. It's 2nd in terms of the ranking in terms of population attributable risk. So we mentioned that we don't know what the prevalence of smoking is among TB patients, which is kind of seems like a no-brainer that this should be recorded on all of the TB cases, and I'd like to encourage CDC to start looking at that as a requirement. But we do have some information about smoking in LTBI in U.S. adults. This is from the NHANES, which is a medical examination health information survey that is done periodically, and recently included both a biochemical measurement of cigarette smoking and passive smoking exposure, as well as a skin test for TB. So of the 3,000 respondents in this survey, nationally representative respondents, with a TB skin test and cotinine levels, which is measured in the blood as a nicotine metabolite, we found that there's 28% of those who were active smokers, which is a little higher than the kind of U.S. population estimate that was presented previously. But we know that also 34% were passively exposed to cigarette smoking. They had cotinine in their blood that showed that they weren't smokers, not high enough to do that, but to be exposed to smokers in the worksite or the home. But of these, 2,900 or so adults, 8% were actually skin test positive for TB. So we could put these data together and control for age, gender, race, ethnicity, socioeconomic status, household origin, or rather country of origin, household size, history of BCG vaccination, and having lived with someone with known TB. And we find that active smokers have double the risk of latent TB compared to non-smokers. So smoking's bad for TB on a population level here, and that we can see that this is something that needs a little bit more exploration in terms of research. Now, what happens with smoking and TB? Well, there's actually structural damage in the respiratory system due to smoking, where the cilia, who are responsible for getting contaminants, foreign bodies, infections, infectious agents, etc., out of the lungs, ciliary function is impaired. So the clearance is impaired in the lungs. The immune response, in addition, is also impaired, and that is those things that would be adverse to the mycobacterial infection are attenuated, and nicotine itself, the drug nicotine, turns off cytokine production by macrophages, which allows this activation of LTBI to occur. So there are local surface-related activities, immunologic activities that are impaired by smoking. And then, on the social or sort of clinical approach to TB, we know that smoking, along with alcohol and other kinds of adverse behaviors, is associated with dropout from treatment, delayed smear conversion, and longer infectivity. And then the social contact that is involved in smoking influences the spread of infectious diseases as well. And I would ask the question of our colleagues from Boston whether or not they have a completely smoke-free policy in the homeless shelter that they deal with, just to emphasize the need for sort of an ecological approach to smoking and TB as well. Well, at any rate, there's lots of social determinants of TB that are also shared by the smoking risks: poverty, crowding, urbanization, access to care, and information asymmetry. I think this is an important one, and if you were to ask the patients in some of these treatment settings about what they knew about the relationship between TB and smoking, there wouldn't be much information there. Now, we know that smoking goes down with educational advancement and information, but those who are at the lower end of the socioeconomic scale are not going to have access to that kind of information, so it behooves TB treatment programs to provide that kind of information. I put solid fuel stoves in homes down there. That's a global health problem that's almost as bad as passive smoking in terms of TB infection in households. Well, at any rate, what can we do with TB treatment and smoking cessation? Well, so far there really hasn't been much evidence on this. Both in the U.S. population, but also globally, where we can have a lot more access to patients with DOTS treatment. That is the regular provider-patient contact, perhaps daily, perhaps twice a week, for 6 months. And this ought to be a teachable moment for smoking and other kind of risk factors. But what we've found, at least in trying to embrace these dual epidemics, colliding epidemics, is that there's very little communication between the people who are involved in smoking and those who are involved in TB control. It's almost as if they're two separate universes, even within organizations like the International Union on Lung Disease and TB and the American Thoracic Society. Well, at any rate, we know all the bad things now about smoking and how it adversely affects TB infection, progression, mortality, and smear conversion as well. So why doesn't this happen? Well, there's plenty of recommendations about smoking cessation. I would like to just point out the Guide to Clinical Preventive Services, which is available online to you. Talks about all the sort of standard approach that's recommended, evidence-based approach to smoking cessation, which starts with taking a complete history, just as was mentioned, the history of alcohol use, and that everybody who smokes should be offered cessation counseling, and this may be enhanced by direct face-to-face, unambiguous, brief, informative statements. It doesn't take much to say smoking is really bad for your TB treatment and you need to stop, because it's not only reducing the effectiveness of the medication that you're trying to take, but it's also it provides a risk to those around you because of the increased spread in households and social contexts. In a clinical setting, we sometimes set a quit date with patients to say, okay, well, this is the date that we agree that you're going to quit, and you need a plan for that. Reinforcement is really needed. Support visits, follow-up telephone calls, public health nurse actions in field work. And then there's lots of self-help materials, 800 numbers, cessation lines, etc., that can be used and referred to, but they need to be accessible to patients, and that information needs to be available to them. Now, the question arises whether or not drug therapy is needed for cessation, because there's an awful lot of advertisement on that I think you can see on television, and there's a lot more choices now. For instance, nicotine replacement therapy, otherwise known as NRT in our business. Patches, lozenges, gums, over-the-counter stuff is available. Some states cover this on Medicaid. There are prescription drugs like Nicotrol, which is an inhaler. And then there is a lot of information now about harm reduction with new tobacco products like electronic cigarettes and snus, which is smokeless tobacco that you don't even have to spit out. A lot of controversy about this. I myself and many people in the tobacco control community say, no way. Harm reduction is not the right idea because it keeps people addicted to nicotine and then allows recidivism to cigarette smoking to occur. There are new drugs, those that block the effects of nicotine in the brain, of nicotine agonist, varenicline, which is new and available by prescription, and then antidepressants, bupropion, which go by the name of Wellbutrin and Zyban, that also are shown to be effective even when added to nicotine replacement therapy. So there's lots of choices. Whether these interact with TB drug treatment is a major question. Now, is it effective? Well, there's, again, as I mentioned, lots of evidence, and what we call effective is abstinence from cigarette smoking for 6 months or more. Self-help, even with just self-help tools, brochures, 800 lines, that has an odds ratio of 1.2. In other words, it's 20% more effective than no help at all. And the advice gets a better relationship to cessation, which is about 75% more effective than no intervention or no advice. So even that alone is an important thing to say, okay, you quit smoking, please. It's important for your TB treatment. Intensive advice, well, maybe it's not even a big advantage over just brief advice. Group counseling increases the effectiveness of smoking cessation, so kind of referring patients to group therapy will help. Nicotine replacement is helpful. It's 50% more than than placebo at least, and even telephone counseling has an increase in terms of the evidence for effective smoking cessation. Well, there's a lot of information gaps in this process of getting people to quit smoking. Well, first of all, does inclusion of a smoking cessation program in TB treatment improve cessation? Theoretically, you've got a lot more contact between a provider and a patient, which, as we've shown, the evidence is that face-to-face contact on smoking cessation helps. And compared with just sort of brief advice or no advice, theoretically, this ought to be a lot of improvement in smoking cessation. Does smoking cessation improve TB treatment outcomes? And ones that we've talked about in terms of impacts are smear conversion, that is, reducing the time of infectivity, which could have a big public health effect, and reduce the relapse by increasing the patient's sense of lung health in general. And does smoking cessation increase, or rather decrease the spread of TB in households or contacts? Well, that's a good question because there's lots of evidence, international studies, as much as 9 times the risk of TB cases in smoking households compared to non-smoking households. And then, of course, the question about what happens with NRT, bupropion, varenicline, et cetera, in TB therapy. Well, right now, what the advice from the WHO is, as well as the International Union Against TB and Lung Disease, incorporate brief advice on smoking in all TB treatment programs. And I guess I'd just like to ask the question, is that done in the places where you all work? The clinical interventions that WHO recommends are the 5 A's: asking if the patient smoke, advising them to quit, assessing their willingness to quit, assisting them either with, therapies or perhaps chemotherapies, and following up. These are the important things. And that's, I think, the basic part of TB, rather smoking cessation and TB. So do we have evidence in places where smoking cessation has been implemented? Well, not a lot. In fact, there's none. Right now, this study that I found in Taiwan, where they had a cohort of 486,000 adults followed for a goodly period of time, found that the hazard ratio for smokers versus non-smokers is something that we would expect, pretty high actually. The death for smokers versus non-smokers with TB was pretty high, but after quitting, the risk of death from TB was reduced by 65%. So, and here in Taiwan, as we've seen in the estimates that I presented earlier, about a third of all the TB and mortality in Taiwan was accounted for by smoking. So we've got some evidence, not a lot. I'm involved in a study in Brazil. My wife is an infectious disease specialist there, and we had access to the TB clinics in Rio de Janeiro, where there are 7,000 new cases of TB each year. It gives us a lot of clinical material to work with. And we train TB providers to do smoking cessation. And we implemented this in a couple of the TB clinics. There was good results of the training. People really liked it, but what we found was that there was very little ownership by the TB providers of smoking cessation, lack of follow-up, and they tried to refer patients but did not implement any kind of counseling as part of the TB program. There's this divide between TB and smoking cessation that still has not been adequately overcome, even when we really tried hard to get the training done. Well, so will it make a difference? Here's the questions that I think you should all just think about. Is there evidence of effectiveness for counseling for cessation in TB patients? And what will it take to get the TB providers to provide such integrated treatment for these two lung diseases? So in conclusion, I'd just like to mention, or just like to say that smoking does increase risk for TB on all sorts of levels, mortality, morbidity, and household spread, as well as contacts, and that the 5 A's of smoking cessation, there's evidence to show that these things increase cessation success in all smokers, regardless of SES and other kinds of risk factors. TB patients or TB program providers may benefit from being trained to provide the 5 A's, and that we need clinical trials of cessation in various populations to show the impacts of these on TB treatment success as well. No matter what, at this point, I think there's plenty of evidence to show that smoking cessation should be a standard of care in TB treatment. So the next steps, the Surgeon General's reports coming out this year, that is supposed to come out every year, will make some comments about the relationship between TB and smoking risks. This will help. It puts it into official government language. There are going to be some randomized controlled trials in several countries where I've been working, and we need to look carefully at the interaction between drug treatment for cessation and TB, and to tailor specific programs for specific populations. So, thank you very much. I appreciate your attention.
Great. Thank you, Tom, as well. I think we're going to move to a little discussion among our faculty first before we open up for questions from all of you. And I want to just stop for a minute and say it's really, listening to Tom's talk and looking at some of the data, I'm struck by the fact that this should be an eye-opener. To think that the population's attributable risk to tobacco, to our burden of TB that we care for, is up to a third of the caseload. And it makes me think that this should be a wake-up call. And those of us who work in frontline TB clinics, we should really stop for a moment and think about what can be done. And I do want to call on Eric. Eric here in the picture with his son Nathan. Nathan can probably join in too if he's there with you, Eric. But really, what can we do on a national level? Let's start with that first.
Lisa, I think it's a great question, and I think there's a lot of opportunities for guidance and for CDC, along with other leaders in tobacco control in the U.S. and working in partnership with the states, really to get greater emphasis on data collection and evaluation of programs that are currently done and being implemented, and then looking at what we can do to really bring together and integrate a number of services, because there are existing tobacco use cessation services in all states, and there's also substance abuse treatment services in many locations, mental health services, and other programs to really provide more comprehensive care and services for our patients with TB.
Thanks, Eric. And Tom, I'm going to turn to you next because your work in Brazil and your work with the groups of providers who are implementing smoking cessation into their TB clinics, the issue of lack of ownership. Now, that's something that I think here in the U.S. we'll struggle with because, of course, we have what we have a problem every day with lack of resources. Do you have any more comments? What do you think people can do here to really buy into attacking the problem of smoking within their TB population?
Well, I think there needs to be a sense that the standard of care includes smoking cessation, includes attention to that. I think alcohol, deserves a lot of attention too. I mean, we've certainly seen the evidence on that, but it just doesn't seem logical not to say that cessation of smoking. It's almost as if you were dealing with a patient with cardiovascular disease. That patient's going to be really advised strongly to quit smoking. It's part of a standard treatment. And, we've seen lots of evidence regarding the interaction between non-communicable disease issues such as cervical cancer and infectious disease issues, which would be human papillomavirus, stomach cancer, and Helicobacter pylori. So, the relationships between infectious diseases and non-infectious diseases, are becoming more clear. But in TB, it's, I think, just been remiss in not saying that this is a standard part of TB treatment, and that's what I think we need.
Well, maybe part of it is, of all the interventions we can make, tobacco seems to be so ubiquitous. But I do want to say that the data from Taiwan, it's as if we actually intervened and people stopped smoking. They would actually have a decrease in mortality from TB. Is striking. And Claire and John, all right, here we are. We're all in clinics where we're getting cutbacks right and left. We have people in our care closely every day for 6 to 9 months with daily treatment often. Can we do this? Can we add smoking cessation into what we offer folks? Can we try to get them into programs? Is it feasible?
Hi, Lisa. It's Claire. Absolutely. The question is, we have to make it. I mean, I don't even think there's a choice. I mean, we've seen the data here and seen what smoking does generally, but what it does in terms of TB management. I think we have to find a way to make it as institutional as is, when our patients come in the DOT. It needs to be part of the Bible to say to our patients, look, we understand, and if in education, it all goes back to education, but we have to integrate smoking cessation somehow. We have to find the time. We have to find the money. We have to allow that. We afford this. We have to afford it to our patients. I mean, it's something that's a definite that we have to do.
Well, I think
if I can add, it's all part of the process. It's all part of the relationship you build with the patient on the one-to-one level, and we do this with smoking cessation. What Claire didn't say was that she works in a smoking cessation program, and we send patients from our shelters over to the program.
So just like with our webinars on diabetes, where we've really kind of taken under our wings the ideas of really screening closely for good diabetes care and control, tobacco seems to be something that we should be adding to the list. And I love that Tom gave us a reminder of really just those basic steps we can take, just like in the primary care clinics, where you can make a difference just by talking to your patient about it. But I want to switch gears for just a minute of discussion, because I know when Denise Ingman first brought up the idea of doing a webinar addressing problems with alcohol, she brought up a lot of the basic questions that she gets often from people in her area who call with questions and consultations. And it's really, we struggle with these dual problems all the time. Someone who continues to drink and has TB. And some of the really common questions are, again, can you feel comfortable going ahead with rifampin for 4 months like John does, John and Claire do, because your patient says, you know what, doc, I'm not going to stop drinking. Can you give me something that's a little less toxic? John, Claire, rifampin as an alternative treatment?
Well, I'm not going to speak for John, but I can speak for both of us in a way. I mean, for us, I think you have to tell them what is absolutely true. We do not want you to drink. We don't want you to have one drink on Friday. We don't want you to have two drinks. I think you open yourself up as a provider and a clinician for a lot of issues, because patients will say, the physician told me to drink. The nurse told me that it was okay to drink. You know, we understand that it is very realistic that our patients drink, but I think for me as a clinician, I tell patients, I'm telling you, you can't drink. And I continue to monitor patients. You know, you might come in every 2 weeks instead of every 4 weeks. So I might make the decision, I'm not happy because I know that you are drinking so much that I choose not to offer you this treatment. Because I don't think you can. From a clinician point of view, it's that simple, it's that black and white.
And we tailor it to the individual. We tailor our monitoring and our education and our relationship building with the individual. So one of the reasons we like to think about using rifampin and actually use it is that it's only 4 months in duration. The evidence that it's less toxic than INH is limited, but we believe that it's probably less toxic to the liver than INH in some respects. But it's only 4 months in duration. And while rifampin affects many other drugs, and there are many other reasons to be careful with using rifampin as an agent besides the evidence, if we only prescribe it for 4 months, it's a period of time we tell the patient to limit their drinking or not drink at all for a shorter period of time. 9 months is a bit of a daunting future for these guys to think about.
So how about with active disease? A lot of our patients have both active TB and problems with substance use, and actually one of the questions Denise brought up, they also have active Hep C or B in our substance abuse populations. And one of the questions was, do you ever go straight to a liver-sparing regimen? Is there criteria for deciding on this?
Well, again, we do it on an individual case basis. We look at the patient and his liver function, and we work with the liver docs and the primary care docs in this context. And if the hepatitis is active, we're sure that there are going to be problems with the liver. We go right to a liver-sparing regimen and try to avoid the liver-toxic drugs. If not, then we might insist on monitoring them more closely, like at least once a week while they're taking therapy. It's a lot's based on whether they can understand the consequences of toxicity and the symptoms of toxicity, and know to come back if they're feeling ill.
Well, thanks, guys. I think I know Denise gave me a long list of possible questions, and I think the message I'm really hearing is really, I guess what we do is we have to look at these individuals and the risks and benefits, but we shouldn't be afraid to forge ahead. Go ahead, John.
Yeah, with treatment of latent TB infection, the two drugs that we use have potential to injure the liver. So with hepatitis C, we know the risk of toxicity from isoniazids maybe 5 times greater than without hepatitis C. So we usually try to get the patient into treatment for the hep C before we bring them back to start treatment with INH, for example.
All right. Well, we're going to have to close up because we only have a couple of minutes left, and I think you've seen flashing on the slide is the potential for going ahead and writing us questions that we could answer later offline with an email. We often consolidate questions. If you can't figure out how to do this on your computer screen right now, feel free to send in the emails with questions. And in fact, if you have success stories of how you problem solved around both of these addictions of alcohol and tobacco and advice you'd want to give other programs, let us know, and we can compile all this for an FAQ. I'd like to thank again not only just all of our audience who tuned in, but also our fabulous faculty. Kelly is going to close out with just some last-minute information about how to get those credits again. Thank you all.
Thank you. This concludes today's web-based training, and we'd like to remind you to please remember to complete our evaluation. We'll email you the web link to the evaluation immediately after this seminar. So if you have not been able to receive our correspondence by email, please contact Bob Siedelkon soon after the seminar. And here is the contact information. The email address is webworkshop@nationaltbcenter.ucss.edu. Thank you.